welcome to this wonderful morning. We can see it's a bright sunny day and we are here for an all new pattern of a conference which is called Rodinar. So here we are going to visit a few wonderful locations in Kolkata, such as the one where I am standing right now is Prinsep Ghat. And along with this, we are going to have a very nice, friendly, informal discussion on the topic called atopic dermatitis. Myself, Dr. Prerna Raj Gupta, I am a consultant dermatologist working at Skin Vita Clinic. And along with that, I am associated at NRS Medical College. Also, I am founder at Skintastic Clinic and director at LifeWorks Global Private Limited. So today for this wonderful lively discussion, I have with me Dr. Siddharth Das, who is professor at VIMS, and Dr. Nilendu Sharma, who is HOD at Malda Medical College.
How's everything there?
Hello,
Good morning.
sir.
Hello.
Nice to see you, Prerna, after a long time.
How
How are you? Fine. Yeah. How's everything there?
Very good, sir.
Good morning, Siddhartha. How are you?
Oh, fine. Thank you.
Everything is fine in Kolkata?
Yeah, everything is fine here in Kolkata. How is everything in Malda?
Absolutely fine.
Let's have a great start to the day, sir.
Do you know the nearby this Prinsep Ghat and the nearby this Babu Ghat is very popular among the students.
Yes.
Whenever they don't have class, it is very common practice to come this place.
Exactly. And then, I don't know, for renovation, maybe it is closed now, but then we used to go down over there on the stairs.
No, actually, yes, maybe
dip our
renovation, but
legs.
for the last 2 years, the entire area was closed. I came here in the December possibly, but the main gate was closed. Now it is again open.
And we also know that Parinita was shot over here in that monument.
Yes.
So let's take a stroll down this place.
Oh, sure.
Yes.
I love it.
This place is very popular for morning walkers.
Yes.
Yes.
So it's good na, that we are meeting in the morning at this place.
And the maintenance has been very good because it is seen by the military.
Yes.
Sir, of all the diseases, I find most challenging atopic dermatitis. What is the trend like in now, like the current scenario?
In fact, atopic dermatitis, we know, since ages, it is one of the very difficult condition to treat for the dermatologist. It affects children and also adults. And many times we can find that the disease has got a remitting and relapsing courses.
Right.
And we have got so many therapies, but nothing is foolproof. We cannot say that we can really cure to the disease. It's really a difficult one and really challenge to the dermatologist.
See, in this situation, I would like to remember one thing. In my PG days, for the first few months, when sir diagnosed a case of atopic dermatitis, I could not understand what exactly is the disease because so many different presentation, the final diagnosis is AD. So one of the intern who was sitting beside me asked me, sir, what is AD, how to diagnose? I told her that, see, whenever you don't understand anything, it should be AD. So AD was like this, so varied presentation at some place where it is very cold like Ranchi or where I did MD. So it was very common, much more common than in Kolkata.
Yes.
I used to see a lot of AD patients during my PG ship. Now I understand that the weather has a very important role in AD. I used to see a lot of cases of AD there. Even I started a study there during my PG ship. The people who are coming to this place like Ranchi, they didn't have any manifestations of AD, but once they reach Ranchi, they started having this AD.
The disease gets
So
triggered.
environment has a very important role. We could not finish the study, but it was very important, this finding, that place and environment has so important role.
I agree with Nilendu because environment has got a really great effect on atopic dermatitis. And another thing also, like to diagnose AD is really misleading and many a time it's become very difficult. In fact, in dermatology also, like everything looks alike. So that is another challenge to the dermatologist because you should know what you are diagnosing.
And more so because of the unique presentation of this disease.
Yes.
In
Exactly.
different patients, it presents in a different way with papules,
Now
with
we
plaques.
see more this allergic contact dermatitis
Yes.
Right.
in Calcutta and surrounding Calcutta. We see more of allergic contact dermatitis, some irritant contact dermatitis, and they have almost similar presentation. I remember then it was mentioned in UK diagnostic criteria. The primary criteria was persistent itching,
Right.
and in a small letter it was mentioned you have to rule out scabies. Now it is mostly written you have to rule out allergic contact dermatitis and other eczematous conditions. So these things have also increased, but presentation is almost same. So it is very difficult, not
So
always
we
very
use
easy.
this phrase for atopic dermatitis, the itch which rashes.
Exactly,
Itching.
exactly. Basically, primary presentation is itching.
Right.
So patient may not develop that kind of skin rash, especially in places like Kolkata where there's a lot of moisture in the air. The patient may not have that lichenification that
Right.
is seen in the colder places
Right.
like Ranchi or other places where they dry and cold weather. They develop more chronic eczema. In Calcutta, we may not have that kind of severe this lichenification. So itching is the primary this presentation.
Sir, at which age the patient mostly presents to you? Kids of which age?
I have seen people like 3 months even above also. Like most of the pediatric age
That
group,
young.
they start at the beginning. Like it can start from 3 years or above also. Even we have come across with adult atopic dermatitis also. But most commonly it started with a younger age, and even many times they keep on rotating to the visiting many dermatologists.
So, sir, the moment you tell these patients that there is no cure for the disease, they get very disheartened. So, how do you counsel them?
No, actually in dermatology, most of the diseases have this kind of
Right.
this prognosis. So you should not. I don't like this phrase that the disease is not curable. So we should not utter this kind of thing. This is a very negative approach,
Right.
even for the psoriasis, even for other disease.
Exactly.
When you know that the disease may have a long chronic course, we should not tell that it is incurable. Actually, there are a lot of things that can help the patient. We have to tell these things, we have to counsel in that way. So, this is not curable, we should not say in that way. That is a negative approach, I feel.
No, one more thing, because I see a lot of patients of psoriasis. They have moved from like West Bengal to Delhi to Chennai, everywhere. You have to go with a prolonged treatment, and remember that you may not be get cured, or in fact you may got cured also. You don't know because how it progresses. Atopic dermatitis is the same way, because you have to get the treatment to keep it under control. Because if there is a lot of exudation, a lot of casting, that may lead to more infection. So infection in a child is really threatening. It can, if there is secondary infection, that can really problematic. So we should tell. That is the most important thing.
Sir, what do you have to say about crisaborole, the new molecule which is coming up?
Crisaborole is a new novel medicine which will be very much effective in the treatment of mild to moderate atopic dermatitis in the treatment of children. Basically, they are the most sufferer, and obviously also we have many patients are coming with atopic dermatitis in the adults also. Basically, crisaborole is a boron-based novel molecule which inhibits the phosphodiesterase 4 activity by competitive or reversible way. So, what this crisaborole does, basically it inhibits the phosphodiesterase 4 inhibitor, and this phosphodiesterase 4 inhibitor, it does increase of the CMP, and this increased CMP has got a regulatory effect of T cells, and that means it prevents the mediators or inflammatory mediators like interleukin 4, interleukin 13 and interleukin 31. So this way it is very much effective, of this prevention of the phosphatase inhibitor, and also it prevents the mediators. And so one more thing is very important, that we can apply or skin sensitive areas in the children. Even we can use this medicine even 3 years, 3 months or even more aged patients, where it can be shown, it has shown that no much complication is there, pretty safe medicine. Another advantage of this medicine is it not only blocks the, prevents the phosphodiesterase 4 inhibitors, it inhibits the pro-inflammatory cytokines, and also it has got very minimal or less side effects. In fact, we know that we have got a different set of treatments like topical corticosteroids or calcium inhibitors like pimecrolimus 2% or tacrolimus 0.03% or 0.1%. But all those patients have got some side effect or something. Even we cannot use a prolonged use of corticosteroids due to systemic side effects. So this is the advantage. Another problem with systemic steroid, like we can all know that the side effects includes skin atrophy, telangiectasia, staph formation. Also, if there is an absorption, systemic absorption, that can lead to hypothalamic pituitary adnexal axis suppression. So crisaborole is very safe. It's topically used twice a day, and it's one of the very novel medicine and novel treatment for the children. Even we can give this medicine up to 3 months or age with patients of atopic dermatitis. So in near future, I believe this molecule will I think be launched in India very shortly, and it has got unique advantages and less side effect. And another good part of it, this molecule is it prevents the like skin barrier integrity also, and at the same time also very quickly absorbed through the skin. So that means very minimum or less systemic absorption. So chances of being the side effects are very minimum or less.
So what is your approach to treatment in patients of atopic, mild, moderate and severe?
See, so far we treat atopic dermatitis patients with different kinds of topical steroid. Topical steroid is this cornerstone of the therapy of atopic dermatitis, but the problem is the disease is very chronic. So you cannot use chronic topical steroid for a long time. During 2003 or 4, this tacrolimus came, and after many years pimecrolimus came. So then it was non-steroidal topical application, though the potency wise they were less potent than topical steroid, but the main side effect of topical corticosteroid like atrophy and other side effect absorption was not there with topical this tacrolimus. Now if the patient is not improved with these topical medications, you have to use some other medications. It is said that AD is not mediated through histamines. There are mostly other mediators, but in practice we mostly use antihistamines because histamine has no role. It is not true. Histamine has some role. There are other mediators obviously, and symptomatic management of the itching, histamines, antihistamines plays some role, and it is often frequently used. There are other situations when you cannot manage with this, then you need some systemic anti-inflammatory, and systemic steroid is one of the very important option. There is a global suppression of this inflammation, and AD is basically a elevated inflammation. Skin is very sensitive. So due to different this aggravation, different factors, it gets aggravated. Like if it's like little dryness, there is aggravation. If it is more sweat, then aggravated. If you wear a dress and remove it, there is aggravation. And if you use more soap, it is aggravated. AD is basically Th2 mediated disease, Unlike many other diseases where there is a Th1 elevation, Th2 is high in AD. So there are some drugs, biologics like dupilumab. Dupilumab, there are a lot of discussions with dupilumab in the literature, also a lot of discussion in the conferences. Dupilumab is basically reduces Th2 inflammation. So dupilumab is effective. So when we get the drug, we may use it. And now topical anti-inflammatory drug other than steroids and topical tacrolimus. There are these crisaborole has come, not has come, it is in use in other countries since quite a few years. Possibly we will get the drug in India within few months. History is very important about the crisaborole. It was basically planned to be used in psoriasis because it inhibits phosphodiesterase 4. And you know apremilast basically of the same group of drug, oral drug, that is phosphodiesterase 4 inhibitor. So initially it was planned that this drug will be effective in psoriasis, but unfortunately the study, there's a lot of monetary transaction between the innovator and another drug who thought of a lot of financial gain, but ultimately the practical use of the drug was not that fruitful. So then AD was secondary thought for the drug, not the primary thought. So, but fortunately patients of AD improved, and quickly it got approval from the this leading agency worldwide like FDA. They approved, even European agency it approved the drug.
Sir, tell us about some studies related to crisaborole.
Yes. According to literature, 2 studies, randomized, double-blind, phase 3 clinical trial with patients of atopic dermatitis, mild to moderate, at the age of more than 2 years or more, with a study material 1,502 patients were evaluated. And in comparison with the placebo or volunteers, they have seen that the patient treated with crisaborole shows early improvement of the disease. Like that disease means improvement in the signs and symptoms, including erythema, exudation, excoriation, papulation, and lichenification. So all those things were improved more earlier than the vehicle treated patients. One more thing about this pruritus. So there was a marked improvement in pruritus in in crisaborole in comparison to the vehicle treated. It has been seen that 1.17 versus 1.7 in vehicle treated showed improvement in crisaborole. So obviously there is more improvement in the pruritus and intensity of pruritus in crisaborole than the vehicle treated patients.
About your experience and research studies which you've done throughout your practice regarding atopic dermatitis.
Actually, more patient you see of a particular disease, you grow more interest of that disease. So I used to see lot of cases of AD during my earlier practicing period. So I had lot of this interest in atopic dermatitis, and I presented a paper in China ICD. In 2004, I got a scholarship for that paper. It was follicular involvement in atopic dermatitis. Whenever you remove the dress from outside, then you feel that there is a lot of itching. Patient will complain particularly that if I remove my dress after the whole day work, it starts itching. And this is because of the hair follicle. Because there is static electricity inside the hair. So when you remove the dresses, the nerve endings in the follicular ends, they get stimulated, and the patient starts itching. So it is a very intimate relationship between the nerve fibers at the root of the hair follicle, and clinically also you see lot of follicular prominence, this keratosis pilaris. I use the term as atopic follicular dermatosis, AFD.
Correct. Just yesterday I saw a kid 5-year-old with all KP-like lesions on the elbows and the knees.
These are KP-like. Actually, if the follicles are prominent, this looks like KP, but this is not KP.
It's not KP.
This follicular prominence is a very specific feature of atopic dermatitis. You will hardly ever find any other disease.
Right.
So this was my interest at that time.
Wonderful. Sir, what are the disease complications with atopy that you come across very frequently?
Complications in AD are because of multi-pronged factors. One, the barrier parameters, barrier
Right,
is defective.
barrier is defective.
So due to the filaggrin mutations and filaggrin defect, the barrier is defective. So there are multiple infections, mostly staph infections. There are some fungal infections, some viral infection. Herpes is very common in AD. And due to the barrier defect, the normal inherent bacteria of the skins are not giving us a lot of protections.
Right.
So outside infections can penetrate the
Easily
skin.
penetrate.
Second, if you continue to itch your skin, the skin will be mechanically damaged.
Right,
So there will be a lot of infections due to the itching.
right.
And if the environmental factor adds to that, like if there is a lot of humidity, then you will definitely have bacterial infection, because normally even if you don't have AD and during summertime you have malaria, then due to the itching in the malaria there is a secondary infection, secondary bacterial infection. So AD, the chance is much higher.
Correct.
And in case of colder atmosphere where there is less sweat, the infection chance is little different. Means bacterial infection is much more common in Calcutta
Correct.
than in other cold hilly areas. But itching part is there, so they develop more lichenification. Here we develop early infection.
And sir, like we know, we have to give the treatment for a prolonged period of time. So what about the treatment complications? Patients are very much concerned with that.
Obviously, if we look into the treatment, first you have to see that whether the patient is having mild, moderate or severe disease.
Right.
And also what age we are dealing with. Say in the young childhood, say 4 to 6 years of age, most of the patients, they scratches a lot. So there is a lot of oozing and crusting. So chances of infection is very high. In fact, cyclosporin is also another effective mode. But whether you use whether in oral corticosteroid or oral cyclosporin, you should be very much cautious, and you should be given to a smaller period, not for a prolonged period, to prevent the side effects. And this is all the most important part. Even nowadays, severe AD, we can go for also phototherapy. Phototherapy is also another effective mode to prevent and control. And nowadays, good thing is there because of this crisaborole. So crisaborole basically it's a phosphodiesterase inhibitor medicine, and it's a boron based. What is boron based? It synthesizes a low molecular weight compound, which can easily penetrate the human skin. So it can gives better result because of its easy penetration, and at the same time also it can absorb very quickly. That means it can action is faster, and at the same time also chances of side effects are also very minimal. So these are the things is very important. But again, so this crisaborole can be given twice a day, and the advantage part of it, you can give the more younger age, like you can give 3 months or older patients.
Right.
Results are quite faster. Even the studies also show that result is quick. Pruritus, and there's a quite improvement in the pruritus also. So this is another good medicine. Obviously, is coming to India. Now we want this should be, like I believe that crisaborole to be launched as early as possible, and obviously we are eagerly waiting for the result, and obviously we cannot comment as early as possible soon. So we have to use this medicine for longer period, then only we will able to come out on a conclusion that how this medicine is working in India with this diverse situation like climatic situation. That is the most important part.
Yes. Sir, finally, I would just like to ask, what is the scope of spreading awareness in this disease, and do you think that it will help in terms of patient becoming earlier aware about it, about the symptoms that he is developing, and visit the doctor at an earlier stage, and how will the disease progress in that case if they are more aware?
Definitely, in country like India, where the awareness regarding the disease, its prognosis, its management, chance of cure is very poor in most of the disease. Atopic dermatitis being a common disease, and it mostly affecting the children, where the parents are always very apprehensive. Whenever their children is affected, the parents are always apprehensive. So some information, some awareness is very much important, not only for them but also for us to counsel the patient. Because if the patient know that the disease is a chronic disease, it will take some time, then the parent will not come to your chamber and thump on your table. What are you doing for the so many months? My son is not getting improved. So if they know about the disease, then they can prevent relapse. They know these are the factors that can stimulate this aggravation, that can cause, if they know that not the expensive dress is important, it is the cotton dress that is important, not the expensive body wash, bubble bath is important, it is the emollient that is important. Stopping asking the child to train not to scratch is important, not to allow them. They can just ask you, doctor, what are you doing? My child is scratching all over the night. It is also their duty to understand that the disease is like that, so that they also have some role to ask the child, don't scratch, it will aggravate the disease. The disease that starts from scratching, so parents has to know. So this is very important. So
also avoidance of keeping pets and carpets in the house.
Yes.
So
There are
these
many houses have lot of
approaches which needs to
many
be-
houses have carpets and they have sofas. Cleaning regularly is very
Yes.
important. Making the house very clean is very
Right.
important. Not putting a very expensive carpet or the sofa.
So since you took up this food point, so I would just like to know what advice do you give based on diet restriction or modification?
The first very important advice we should give your patient that food restriction is not at all necessary. It will ultimately cause nutritional
Correct.
this problem. So this is only important when they can specifically clearly identify there is a immediate reactions to some food. Unnecessarily stopping the important foods like eggs and milks and wheats.
Sir, what else would you like to add in the
In
awareness?
fact, Dr. Nilandu has summarized very nicely. Awareness is very important issue because atopic dermatitis is a serious public health issue. So we should at least make awareness to the patients and their parents or relatives that what is atopic dermatitis, how it happens, and what is the course of the disease and prognosis. So that is very important. So we should have a lot of literatures to educate them. So importance in quality of life is very important because many of these patients, they may lead to anxiety, depression, or even suicidal tendencies. So we have to know about that. So only one thing. So we should be very much careful and counsel parents, and we should make awareness that what is the disease, what is the progression of the disease, and they should know that this is a chronic disease with remitting and relapsing courses. That's all.
Sir, I think we had a wonderful discussion with such nice locations, revisiting the memories. It was very nice.
Wonderful. Really, I am very happy. After 12 years, I am coming to this Prinsep Ghat. Even Victoria also maybe after 7 or 8 years. So wonderful place, wonderful ambience,
thoroughly
wonderful
enjoyed.
discussion. Really enjoyed a lot.
And to
Really.
learn from two such experienced people was a wonderful experience.
And another
Actually,
thing
we learn by sharing only.
obviously.
We learn so many things.
Yeah, we learned so many things, and even also this is all we keep on meeting Nilandu and myself on many discussions, on seminars and conferences. But this is something unique that
We are meeting on the road.
on the road,
Yes.
and it's a really unique thing. It happened.
Okay.
Okay.
Thank you, sir.
Thank
Have
you.
a lovely day.
Okay.
Thank you very much, sir.
Bye bye.